going to go ahead and kick off our call. So this is the second one of these, and going forward that we'll be splitting with Inhale. So we at MCTTD are going to take like the first half hour or so of time, and then when we're finished, we'll hand it over to Inhale. Any POs that aren't also participating in Inhale can go ahead and drop off at that time. So we'll let everyone know when it's time to make that switch. As far as today, I have some updated VBR timelines that we wanted to make you aware of due to some changes in the reporting requirements from Blue Cross Blue Shield on that. We have an update on our primary payer coverage VBR. So this was a VBR requirement that is for both cohorts 1 and 2, and we hadn't really defined it yet or what we wanted to do with it. And we have some better definition on that now that we wanted to talk through with you. We'll go through what you can expect related to the data this year as we continue to work with MDC to make updates and get additional sources. And then we'll just have some general updates that we'll kind of go through, just one slide each at the end. So related to the updated VBR timelines, just as some reminders, so we have prospective VBR, at least we have to this point where we've only done participation measures. When we do switch to performance measures, there will be like a retrospective VBR where a measure is met and then they're paid out on. But for the way it goes right now, when we make those payments beginning in September on the codes that your physicians are billing and earning VBR on, they have not yet met the requirements to earn that VBR. So what happens is on September 1st for PCPs and on March 1st for specialists, the physicians begin earning like that VBR, and then throughout that VBR year, they meet the requirements as they come up. So initially Blue Cross wanted the names of the physicians that had met like the prior year's VBR metrics when it comes time to renew it in early January and then mid-July, but they needed to move up these timelines for their own internal like validation and data loading processes to June 1st for the PCPs and November 30th for the specialists. And like we mentioned, because our VBR is prospective, if a physician didn't meet those requirements, Blue Cross does not want to renew their prospective VBR for that next year. So hence when we turn those into them. So I wanted to go over the few deadlines that this update, like moved up deadline impacts. So for PCPs, the cohort 1 PCPs, so those that joined in 2021 that are in their second year of participation, the only requirement that it's going to impact is their learning community requirement. So between now and June 1st, we have that option that always exists of submitting feedback on one of our tools so they can tell us how using that went and we can make edits and incorporate their feedback. There are 4 learning community events between now and June that can either be attended live, the first one coming up this upcoming Monday on the 13th, or watch a recorded version later prior to that June deadline. So when we roll these out after they're initially offered live with CME provided this time, we'll make questions that go along with that recorded version. And so they don't need to be available to attend a live event, and they'll still have multiple opportunities to meet it. So that's moving up from being due in mid-July to now June 1st. For the cohort 2 PCPs, in addition to the learning requirements deadline, which of course is going to change for them too, the other change that this will move up is submitting the case summaries. So we did change these this year because we heard from you last year about it was really challenging to track down and get 3 of those from each physician. So now they are 3 per practice, 1 on each initiative. We're going to be distributing the case summary forms on 2/14. We're just in the process of doing some final review and sign off on them right now. And these will be due on June 1st as well. So hopefully, because it's at the practice level and there's much less of these required, it shouldn't be too much of a challenge to move that up. And then for the specialists, these are the changes that are going to be impacting them related to this deadline change. So for the cohort 1 endocrinologists, so those that are in their second year of the program, we're recording a session on CGMs and medications that will now we do on November 30th instead of like the very end of the year. I actually think these changes will be helpful. We previously had a lot of our specialist deadlines at the very end of the year, which is just a busy time and a lot of people are out of the office anyway. And this is so far in advance that this shouldn't be too much of a shift in the plans that they have to complete these. And then for the cohort 1 nephrologist, same thing. There's going to be a recorded session on emerging uses of GLP-1s and SGLT2s that they'll just need to complete a month earlier than they previously had. For the newly joined endocrinology and nephrology sites, same as the PCPs, there's a couple of case summaries that will be due for them. One for physician, we did keep them at the physician level in this space, that will be due at the end of November now, again, instead of 12/31. Any questions on the updated VBR timelines? And these have all been posted on our website under the VBR tab. There's a place that lists out all the measures by the different cohorts, and they all have these new timelines reflected there. And we don't anticipate any farther changes or moving up of these timelines like in upcoming years. It's our understanding that they're going to stay pretty stable with that, meeting the PCPs by June 1st and the specialists by November 30th. Any questions at all? Okay, so moving on to our primary payer coverage VBR. So we had mentioned that at least, oh, there's one thing in the chat. Yeah, to that point, they're not updated on the administrative portal yet. Do you mean the deadlines, Kathy, or like more specifically the actual metrics?
No, the actual metrics, because I'm looking at the VBR metrics portal now, and for PCP year 1, cohort 2, it says case summary, low carb, case submitted. It has MA.
That just means one hasn't been submitted yet because we haven't made it available for them to be completed. So when we launch it on the 14th, that won't say NA anymore. It'll most likely just be blank until one is submitted, and then there will be like that green checkbox there.
And then is it required that the clinical champion for cohort 2 attend the spring 2023 regional meeting?
Yes, it is.
Okay. Thank you.
Yep. Okay, so for our primary payer coverage VBR, the previous version we were going to do for this, or how we were initially conceptualizing it, was that we were going to try to provide educational materials and resources on coverage related to a specific payer, and then someone at the office would view those and take a short post test. But in reviewing the information that we already are providing via like our coverage tool, which is updated quarterly and should be out available to you soon, and like the patient assistance programs information, we weren't really coming across a lot of additional information that would be useful to be shared like at that payer level that was in any more detail than we'd already been able to provide to the collaborative. So we tried to take a step back and look at how we might provide support in this space, other than our initial conceived idea of that. And so we spent a lot of time thinking about how we could make this useful for the practices and maybe shift away from that initial idea. So what we are planning to do now is, instead of like creating these materials and resources that someone at the practice needs to view, instead we're going to break this into a few separate activities kind of tied into the regional meetings. So when filling out the regional meeting registration, or they can have it emailed to them separately, clinical champions will be asked a brief 8-question survey about coverage at their practice. I have the questions on the next slide, so we'll take a look at those together. And then from the information that we get on that survey, we're going to share some back with the collaboratives at the regional meeting based on the results we get there. We do ask for practices who are successfully navigating prior authorizations or CGM coverage or copays in a way that they found effective, to share that with us via a short call. So again, we'll look at that when we get to the survey specifically. But then from like this information and a activity that we're working on developing in the coordinating center, we have like that hour that's blocked off at the regional meetings to specifically discuss coverage and coverage challenges and ideas and complete that activity. So that's the second component of this. Instead of having this be something they're doing on their own, we're going to discuss this together at the regional meetings. And then the one other thing they'll have to submit following the regional meetings related to this is just kind of a short follow-up or takeaway like from the regional meeting discussion. So maybe they heard an idea there from someone at their table that they're going to try to implement in their practice. So it would legitimately just be writing a sentence or two about that. So we've shifted away from this more independent viewing materials on their own to something that we're hoping will be more interactive, more tapping into that collaborative aspect where we're sharing ideas and learning from each other. 1 second to go to. Yes, question in the chat about updating the calendar document to reflect the VBR requirements moving to 6.1. Yep, we will do that, John. Thank you. So this is the coverage survey that we are asking. When the clinical champions go to register for the regional meeting, they'll have an option to view these questions and either answer them right then or say that they're not ready to answer them then and have them emailed out to them afterwards as a link that they can complete. So really what we're trying to understand and get to better is specifically the biggest challenge related to coverage. I know we've talked a lot about that it's a problem overall, but is it knowing what meds to prescribe? Is it trying to help patients navigate copays, et cetera? Do you have a specific person in your office who handles all prior authorizations? Do you use any software to handle prior authorizations? What EMR do you use? To what extent does your EMR provide reliable information about what is covered for a patient, since more and more are building in kind of tools that estimate like patient copays? How often are patient copays and deductibles the reason a patient's unable to start a new medication or CGM? And then this final component of it is, does your office have like a best practice or tip that you can share with the collaborative? And would you participate in like a 15-minute discussion with our team about it? And doing that will meet the practice level learning community requirements. So they can get that out of the way too. And it should be a pretty short, painless way to do it. As I said here, it's a way for them to easily meet this learning community requirement. The conversations will likely be closer to 15 minutes. Just want to make sure that we understand what they're doing in a way that we can kind of write it up and put it on a slide. And 293 practices still need to meet the practice level learning or community requirement. So I would strongly encourage those practices that are doing well in this space to consider participating in one of these discussions with us, and then getting that requirement out of the way, and also like helping their fellow practices better navigate some of these challenging issues. And so, like I mentioned, the coverage survey is going to be part of the registration for the regional meetings. It'll be due on March 10th. We're going to use that information to generate like summary statistics for the presentation portion of the meeting, to potentially look at how we might seat people together at the meeting to like foster better conversations based on the answers that people gave to that survey, and then to identify those practices who do have tips and strategies that they can share. And then our intent behind like this regional meeting topic is for practices to come away with new ideas for tools or best practices that they can implement and be able to develop a goal based on what they learned and report it out to us, for practices to share and discuss these ideas, and then to participate in an activity that we describe that will allow them to reflect on their current practice insurance workflows. And then, as mentioned, the final component of this is just that short 1 or 2 sentences on a change that they're going to try to implement to their insurance processes, or submit that their current approach is effective and they don't have any changes, like perhaps one of the practices that did say that they do have a best practice or a strategy that's working well for them. Any questions on how we are planning to execute that VBR requirement before moving on to the next section? Okay, so I just wanted to tell you a little bit about what we can expect with the data for this year. So as I think most know, right now our database online has Blue Cross Blue Shield clinical data and claims data, and some Blue Care Network claims data, but only those that are attributed to a Blue Cross Blue Shield of Michigan physician. We're working on adding in Blue Care Network attribution as well. What we've learned from our meetings with the Michigan Data Collaborative and MyHIN is really for anything else to happen, we have all payer clinical data from the PPQC data files that we've been getting since April of last year. But until we're able to set up the active care relationship service information into the data that we're receiving, we're not going to be able to attribute any patients appropriately like to their providers. So the primary thing that needs to happen with MyHIN and the Michigan Data Collaborative is to get this ACRES piece completely set, and that will allow us to not only match for like the PPQC clinical data, but to be able to bring in like the CCDA data that's a little bit more reflective of the EMR. It'll allow us to bring in some additional labs and information there. It'll allow us to attribute like specialists to providers. So it really opens up an entire kind of area of additional data that we're able to add. So what we are hoping and what we expect to have happen, at least at this point in time, is by the end of third quarter, incorporating acres into the dashboards, and then by the end of fourth quarter, being able to add in all payer clinical data, potentially other pieces of data. So Medicaid claims, for example, we're working on the data use agreement with MDHHS. If we're able to get that relatively soon and acres is put into place, we'll also be able to do some matching there. And then again, like CCDAs, these other ones have a few contingencies as well, but pretty much all of them are reliant on the acres attribution being implemented. And so it's most likely that we're not going to launch a performance measure until maybe March of 2024, because we don't want to launch one only on the Blue Cross population, which is all we have now, and all that we would have kind of going into this next year of PCP VBR. So just wanted to let everyone know kind of where we are with these pieces, and we'll give you updates as well on a quarterly basis as we hear from MDC and MyHIN on how we're making progress on these different goals. They've been able to divide all their goals up quarterly, so we should have pretty clear deliverables and expectations from them on what we're meeting and what we're maybe falling behind on. And we'll keep everyone in the loop. But at least right now, our expectation and understanding is to, at minimum, have all payer PPQC data implemented by the end of fourth quarter. And so based on that, this is tentative and just like a general brainstorming of what like a performance measure VBR timeline might look like, based on everything going according to plan, which we do not know if it will or not. So it's going to be flexible based on if we're able to implement all of these different pieces to get acres up and running. But on the assumption that all payer clinical data and potentially Medicaid claims are added into the dashboard in quarter 4 2023, we'll have that data back through November 2021 for the all payer clinical data at least. And so we'll be able to calculate some baseline statistics off of that. We would plan to spend a lot of January doing some heavy lifting with like the analytics there, understanding baselines, coming up with potential targets and goals, most likely on a measure that we can determine from the clinical data, since that will be our most widely reaching data source as far as covering the entire patient population. That's kind of what we're anticipating at this point. But we did build this in if we wanted to account for claims data too. We would then take that analysis that we've done with specific targets and goals and present the VBR of opportunity with that level of detail first to the steering committee to get their approval and sign off, and then to the full collaborative. We would also plan in this time leading up to January 2024 to work with our steering committee about potential ideas and areas of the clinical data that we may want to look at and use for a measure. And then we would share it with the entire collaborative. We would launch the performance metric and ideally collect data from 3/1/2024 to 12/31/2024, I apologize, which would be the 9 months that we'd be looking at the data for the performance year. We would again end everything kind of in March 2025, because we would, if using claims, need to allow for that 3-month claims run out. So from there, we would analyze the data, determine who's met VBR goals and who hasn't, and report these results out to Blue Cross Blue Shield in June 2025. And then they'd start earning that VBR on 9/1 of that year. Yep, we will share out the slides. Kathy, you had a question. Are these VBR timelines the same for both cohort 1 and 2? I think we will likely launch a performance measure to for both, though that said, in this looking at the baseline data component, maybe we will set different targets for cohort 1 and cohort 2. We'll look at just as a very straightforward example, if we were to look at A1C, if we looked at the collaborative as a whole, and then we looked at the rates for cohort 1 and cohort 2, if we didn't really see any differences between those cohort 1 and cohort 2 average A1C values, for example, we would probably just come up with a general goal for the collaborative as a whole and say we're going to work towards that. If we notice that maybe cohort 2, which has had less time in the collaborative and just less time working on these efforts in general, maybe their A1Cs are higher on average than cohort 1's is, maybe we set one target for cohort 1 and one target for cohort 2 based on that. So it's something that we'll have to just learn more about as we're doing the data evaluation, but we do plan to launch a performance measure for both together, but if it's, we will make sure that it's fair for cohort 2. Any other questions? Okay. Another thing that we're doing right now, so currently specialists do not have dashboards data like the PCP practices do. So how you can go in there and you can click on one of your specific PCP practices and there's a list of patients. Specialists don't have that right now. The reason for that goes back to this attribution piece that we were discussing with ACRES. So it's less, specialist attribution is just less straightforward than that PCP attribution. So Blue Cross essentially gives us a list of like the PCPs that patients should be attributed to in that space, but there's not really something similar for the specialists. So the Michigan Data Collaborative had initially wanted us to use ACRES in order to define these relationships and determine what specialist attribution might look like. But that puts us still back at Q4 to implement that data and get dashboards for the specialists. We would like to try to speed that timeline up and do it earlier. So we're working with Blue Cross Blue Shield to define like what specialist attribution might look like separate from ACRES. And then the Michigan Data Collaborative will use that logic that Blue Cross agrees to. Since right now it is solely Blue Cross's data that's in there. So MDC was comfortable with Blue Cross as the insurer who all this data belongs to saying, yes, this counts as attribution, or no, this doesn't. So these were a couple of approaches that we're generally going to be proposing and discussing with Blue Cross Blue Shield around that specialist attribution. So for example, the endocrinologist one, a patient is attributed to a PGIP endocrinologist if they see a specialist for type 2 diabetes on 2 or more occasions in an ambulatory setting within 2 years, and the most recent visit is within 395 days. So we're planning, and we have some like details and additional rationale for why that is what we're proposing. This isn't final yet. We'll be discussing with Blue Cross Blue Shield and determining the way to move forward. We also were made aware that they have a nephrology attribution model already in place. So most likely, instead of what we have listed here, we're going to go with the attribution model that they have in place for their nephrologist. And that's because we don't want to make reporting confusing to anyone. So if someone's looking at like their HEDIS reports from Blue Cross Blue Shield versus like our dashboards, we would want those patient populations to be defined in the same way so that there's some consistency in the information that's being shared with you and with your practices. So we will align when Blue Cross has an approach. And in the case of like endocrinology, where they don't, we will probably define it together first, and then they will use that when they do ultimately attribute for endocrinologists. So we'll keep you in the loop as we do that. But our main goal of this is to just get dashboards for the specialist practices sooner than the Q4. And then just moving on to some general quick updates. We had our first steering committee meeting this Monday morning. These were the topics that we discussed. So just have everyone introduce themselves, talk a little bit about the goals of the steering committee. We went over in much more detail than was on these slides of the data that we have and what they can expect, because we want the steering committee to have a really strong understanding of the data that's available to us and the barriers that we have there, because one of the main functions that we'll ask of the steering committee is to partner with us in defining what those performance measures will look like. So we felt that that was a necessary background for them to have. And then we talked a little bit about performance measures, both like how we're ramping up to them. So what we've done in year 1 of VBR, year 2 of VBR, or thank you for year 3 and how we'll transition into that performance measure space, and then just different considerations that we'll likely ask the steering committee to make about that. So for example, are we going to measure at the practice level or the PO level or the collaborative level or the regional level? Like there's many different ways that we can look into this. What kind of data source is going to be the most meaningful, what measures have an important impact, et cetera. So just kind of laying the foundation for those discussions that we'll hope to have throughout the year. And we took a quick look at the regional meeting agenda and set plans to meet again in late May or early June, because in addition to defining the measures by which we'll be scoring the collaborative for VBR, we also want to partner with the steering committee in determining what those future regional meeting agendas should be and how we should proceed about those as well. So when we meet in June, we'll start talking about the fall meetings and what things might be helpful and what content we'll want to share at those. So it was a good first meeting, and now we expect to have them on more of a quarterly basis, at least for the time being, or, you know, as needed as topics come up. Other things that have going on right now, we distributed the best practices submission form to all cohort 1 practices yesterday. They'll have about 3 months to complete this. It's due May 1st. This is kind of like a more in-depth deep dive to some of the information that was given into the progress report survey. So we want to understand about practice-specific processes that were implemented as a result of MCDDD or have contributed to the success of participating in the program. And then we're going to take this information and turn it back around so that you as the practices can view it and use it. So we're working with our team to build a queryable database that takes into account all the different practice demographics we ask in the survey. So like, what type of practice are you? Are you one that's part of a health system? Do you have a care manager on staff, a pharmacist? Do your patients struggle with food insecurity, et cetera? So all these kind of different details that might be important to consider the applicability and the ability to implement a best practice. So we thought that having that so it's searchable and they can look for practices similar to theirs would be helpful. That's something that we're going to work on in conjunction as these are submitted over the next 3 months. And then hopefully sometime not too long after they're due in May 1st, we'll be able to share that database out to you and to your practices so that they can use it to kind of learn things that have worked well for others and get ideas. As a reminder, we talked about this a little bit earlier. We have the case summaries that are going to be available very, very soon for the cohort 2 practices. Like I mentioned, they're going to be per practice now, not per physician. And they'll be available early next week and then due on the 1st. We're also going to be opening up registration for the regional meetings very, very soon. Next Tuesday, we'll send that out to everyone. You're going to be able to track who's registered from each practice on your administrative portal. And then that's where they'll have the first opportunity to complete that cover survey that we looked at earlier in this call. If they aren't ready to submit it when they're doing the registration for the regional meetings, they'll get that link and it'll be due on March 10th. And nephrologists and endocrinologists will be expected to attend the spring regional meetings along with cohort 2 practices, really everyone in the collaborative. But we're not going to ask the nephrologists and endocrinologists to attend the fall ones. They'll be doing separate clinical champion meetings with just their specialty type that we'll be working on scheduling or already in the process of. And then just as a reminder, in the learning community events that are coming up, we have the very first one coming up this Monday where Dr. Hung is going to talk about management of chronic kidney disease and new era therapeutics. We'll then have one about billing codes like care management and for billing for non-face-to-face care on March 3rd. We're also going to have someone from Blue Cross there as well in case there's specific questions about BDCM billing. And then on March 24th, we'll have an update on medications like tirzepatide and the new CGM devices like the Libre 3 and the G7 and other things that have come out in the last year or so. And then I wanted to introduce a really cool project that I personally, at least, am really excited about. So another partnering CQI program, Healthy Behaviors of Michigan, they had a tobacco cessation program that they led. And one of the things that they did as a component of that was doing like poster designs, in their case for tobacco cessation. And what we're going to do is for type 2 diabetes, of course. So we have a template that we'll distribute to you shortly and to your practices. And really, it's just an opportunity if the posters and offices, like kind of like it says here, if you look at it and see, wow, this is outdated, or we want new information or new things to cover on it. our design team is going to choose like some winning designs and then create posters, and then we will be able to share these with you in your practices. I just want to show you a few that they made for the tobacco cessation one, because they're really, really amazing. So this is like the template that was used where someone from the practice kind of wrote their design. So this was around stop smoking. They wrote all the text they wanted to see here, and they kind of pictured like having flowers and having this theme of life can be longer, you can stop to smell the roses. So our design team took this initial idea that was just kind of roughly drawn out here, and then created this really beautiful poster that took into account all the different elements that the person who submitted it wanted to include. So that quote and the flowers on the side, but just like this really well designed version of it that does like specifically name the person too, down in the bottom corner, of who submitted this design and idea, so they're getting credit for it. And then it takes them to the smoking cessation website, and they're able to get like printouts of these posters like for their office or share these with patients. Here's just another example of something someone submitted, just so you can see like they don't need to be incredibly intensive or like well drawn out. So our team like took this design and then turned it into, again, this really beautiful poster, keeping some of the same elements of like the lung and the smiley faces, but you know, with that really polished final look on it. So this is something that we thought was really, really cool that was done for the practices around tobacco cessation. Our design team is clearly just very talented with how they're able to make these absolutely like beautiful design posters. So we wanted to offer this to you and your practices as well. We'll send out something shortly, and we're actually working on a design right now that is specific to type 2 diabetes. This came up because one of the practices participating in Jumpstart had an idea for a poster they wanted to see. So when that design's done, we'll share this more broadly with the collaborative, but just thought this was a good opportunity. And people do have ideas to turn it into something designed and that they can put up in their practices. And then the last update I had, just wanted to let everyone know about a few GLP-1 tools and resources. So we sent out earlier this week just like a quick one-pager about supporting patients through GLP-1 RA shortages. So this was emailed out to the clinical champions, it's posted on our Twitter, on our website, and is available to everyone as well. So if your practices come to you with challenges around this, feel free to point them in that direction. We also, too, in the past, we had those couple videos on the injectable medications and walking a patient through exactly how to use them with their specific medication. We do have the full video series now with all of the injectable GLP-1 RAs on our website. So if you want to share these with your we'll share these with the practices, and then they'll be mentioned in the next Learning Community newsletter, and they can show these to patients when they're prescribing one of these new medications, and there'll be a specific one for the medication that they are taking. So hopefully that helps with some of the patient education piece and some of that injectable hesitance as well. And that is all we had. The next PO work groups will be Wednesday, March 8th or Monday, March 13th. And with that, if anyone has any questions, let me know. And Haley, I know I took a few minutes of your time, so I apologize for going over a bit.
We'll be fine. Thank you, Jackie.
Okay, thanks so much, everyone.
Wait just a minute for anybody else who wants to drop off before we start the inhale section. And Jackie, if you want to transfer host, you can drop off too, so you don't have to listen.
Okay, thanks, Courtney.
Yeah, thank you. All right, we are going to stick to our same basic agenda that we have for each of our meetings. We have a little more content this time than we did last time, so we're still kind of working ourselves up to full speed here. A few announcements and updates. The Blue Cross Blue Shield team has approved our updated participation requirements. Again, we made some minor edits to those. We mostly just provided clarification or took out irrelevant pieces. And those were sent out to our POs in January as part of that month's newsletter. If you don't have those or would like them resent, please just let us know. And as part of that, one of the administrative portal pieces will ultimately be defining a clinical champion at the participating practice. We do not have that capability right now within the portal, but please do make sure that your clinical champion at the PO level is identified. Practice level will come at a different time. The tobacco cessation counseling measure update, we are working through that with Blue Cross Blue Shield right now. I know that there are several people we've been kind of having conversations with because it seems to be an ever evolving measure based on some moving targets that we have with what they're looking for. We hope to have this finalized in the very near future. We've done some rewrites. We're going to get some more information out there. Part of the reason we haven't shared much is, to be quite frank, we don't have much information. The monthly newsletter is going to be sent out on the last day of the month. And what we plan on doing is having that be a combination of summary recaps from things we've discussed previously, and then sort of a preview of things that we'll discuss at our upcoming meetings as well. Fortunately, Inhale is growing too. We've been welcomed 2 new staff members. Megan Spiroff came from the research world as well, and she's going to be helping lead our strategic partner and engagement of our different boards and developing our contacts throughout the state. And Brenna Dressler is our special projects coordinator, and she's primarily going to start with the education work group and then branch out from there. We're exploring specialist attribution with Blue Cross Blue Shield and the MDC. We have a proposal in right now with Blue Cross Blue Shield. Most of what was covered in MCT2D's presentation is also relevant to Inhale with a few caveats, and we will share that full proposal once it's been approved and vetted, and make sure that we give some clear guidelines as to what we're going to be looking at for specialist attribution. Similar to MCT2D, we do not have any access right now on our data hub dashboard for specialists because of the patient attribution issue. We did get an updated grid for our 2023 enhancement and data refresh. We can send this around, and we will also post this on our website. We anticipate having that back in our control within the week, and hopefully we'll have a website up very soon. The website is almost back in our hands. There were some delays. We are expecting a go live at the end of this month once we do get that back. Your clinical champions at the PO level, again, should be identified in the administrative portal. And Inhale Learning is our education platform, and it is ready for launch. So you are going to see a flyer come through with a QR code for requesting access to that platform. We would like you to share that with your participating practices and physicians so that they can go and indicate interest for signing up for that portal. We will be submitting mass sign-up lists to our vendor for the initial users. So they will get emails from them asking them to update passwords and sign on and things like that. We'll ultimately be creating a video walkthrough as well so that we can walk people through the learning platform, and we'll likely have some live training that will go along with that if it's needed. But if you have those flyers, please share them with your practices and physicians. Of note, this is not limited to physician use. This can be shared with anybody who would benefit from the training that's being provided or from access to these resources. The general resources that are located within this platform will also be freely available, i.e. without a login on our website when that comes to fruition. We don't have any major updates for our PO and practice recruitment. We are not actively recruiting in 2023, so we will be opening up PO recruitment again in 2024. The next physician practice level recruitment is for PCPs and pediatricians, and the deadline for identifying those interested in joining Inhale is 6/1. We will always have our deadline approximately 3 months in advance of the VBR start. And we will provide ample reminders of this upcoming deadline for physician participation. Our next monthly calls will be in March, and March is the universal month of spring vacations. So you will be seeing me. We have very limited staff in March, so you'll get me for both meetings. And then a couple of quick save the dates for the collaborative wide in June. And our regional meetings will start in the fall. No dates have been set yet, but we're going to do a little bit of polling to find out whether people would like to see those in the morning, in the evening, or a combination of the two. I just want to open up now to see if there's any questions for us or anything that we can address while we're on the call. All right, we will make these slides available to everybody if they need them. We are happy to answer any questions you have or set up separate meetings. And again, we are working very hard on the tobacco cessation VBR. We know there's been lots of information and questions there, but as soon as we have clear information, we will definitely share that with you. Have a great afternoon, everyone.